Go.
So, Dr. Mark Pakianathan, we're here today to talk about your article. Can you tell me a bit about yourself and how did you came about to write this paper?
I work in a big, busy South London sexual health service. We've been routinely collecting information about mental health, substance use, alcohol use, as well as chemsex since the publication of the draft Public Health England framework on inequalities in health in gay, bisexual and other men of sex with men. As such, we've had quite a lot of data on chemsex, substance use, alcohol use amongst gay, bisexual and other MSM in our clinic population, and we presented this at the spring meeting at BASH last spring. And since then we've been invited to write this article on how to assess gay, bisexual and other MSM for chemsex. So
sexualized substance use has been around for a long time. Why the need for a specific assessment on chemsex?
I think chemsex is different because it's a relatively new phenomenon for two reasons. The first big reason is that it's using different drugs. The drugs primarily used in the UK are methadone, crystal meth and GBL, which are related with specific harms if use is problematic. The second reason is that the numbers of people participating in chemsex seems to have increased significantly. So we know from data from voluntary agencies, Antidote in London, in central London, that the numbers of gay, bisexual and other MSM seeking help with the drug problem has increased significantly in recent years. And I think anecdotally most clinicians will agree that there are increasing numbers of gay, bisexual and other MSM presenting with problems or consequences related to chemsex. So I think it's new, people are running into problems with it, we're seeing it a lot more in clinic, and so we need to know what to do.
And so what are the key issues highlighted in your paper?
Well, I think the first thing for me is it helped me reflect on my own understanding of why certain populations can be vulnerable. And when I reflect on gay, bisexual and other MSM, it's made me think about why specific individuals within this population or groups within these individuals could be particularly vulnerable. And I think the paper highlights some of the key issues related to mental health and other issues that might make some individuals vulnerable. So the first thing is setting the scene. The other thing that I've tried to do, or we've tried to do with this paper, is we've tried to stress the importance of communication, because you can't get anywhere if somebody's not able to be honest with you. So communication skills and the importance of being sensitive in eliciting information to enable honest disclosure. The other thing we do is highlight practically what are the physical consequences of drug use or sexual behaviors. What are the tests, things like hepatitis C, HIV seroconversion, PEP, what are the practical things a sexual health clinician should be aware of when assessing a patient. We've also given some practical tips on follow-up, how to follow up patients. Would we need to be more proactive in following patients? So I think there's some practical things that clinicians can take away and implement in their services in order to improve quality of care.
Thanks. And what's missing? What's the agenda for the future?
Well, I think one of the big things that's missing for me is, for alcohol use, we have the FAST audit that some clinics are already implementing, and very validated tools to assess alcohol use. The thing with chemsex, there are not very many, there isn't, as far as I'm aware, a rapid patient tool that patients can use. The other thing that's missing is evidence-based approaches to managing people with problematic chemsex, and we need to work together to devise new strategies.
So thank you very much, Dr. Mac.